I showed the slide earlier about the current ELN guidelines about MRD monitoring, but I think that mostly applies to patients who are undergoing more intensive therapy. So now that we're in the era of lower intensity therapy with HMA venetoclax as primary therapy, especially for older, more frail patients, but moving into the domain of fit patients as well. I guess the question is also, how can we apply MRD guidelines that currently exist to lower intensity therapy? Should we be doing this? And what are the repercussions of doing it? What are the opportunities for perhaps discontinuing therapy in MRD negative patients who are on HMA-Ven? Naval, you and your team have done a lot of work, obviously, in the HMA-Ven world, and probably have most experience in kind of understanding the MRD negativity rates and prospects. So maybe you could start.
Yeah, sure, Jeff. And even to your previous question, I mean, at this time, I mean, as a general blanket, I would say we're not using MRD to kind of stop therapy or, determine transplant, even in intermediate risk. So very similar to what Jorge and Jordi said, we, if it's a FLT3 mutated patient at baseline, especially ITD. Now, TKD, we may think about it, but for ITD, our treatment sequence is intensive chemo, FLT3 inhibitor, consolidation. If MRD is negative, wonderful, we're happy. We tell the patient your cure rate could be higher, 70, 80%, but we're still going to transplant. And then maintenance, we're starting to set up this in vivo scribe high sensitivity 10⁻⁻⁶ assay. So that one, I do think once we implement that, which should happen in the next month or two routinely, we may say no maintenance based on the morpho gilteritinib results. But today in the intermediate, we're not saying no transplant if we achieve a negative MRD, except for maybe a FLT3 TKD with NPM1 or NPM1 alone, which then goes into the favorable group. So in the HMA-Ven setting, it's even more nerve-wracking, and I don't think we've really stopped any patient based on MRD negativity, but there may be a combination of factors, right? And there was a nice study, I forget the name, it was from the group in France, where they did Sylvian, and group showed that you could stop HMA-Ven. And I think Moffitt, you guys, I know David and you also gave patients to that study in patients who are CR MRD negative. And I think they said at 1 year, if you had a CR MRD negative, there was about an 80 to 85% chance that that patient may not relapse if stopping therapy. So if there's a patient, he's 78 or 80 or she's 78 or 80, they are NPM1 or IDH1 or 2, one of the favorable without any of the bad signaling mutations or TP53 complex cyto. They are at 1 year and they're MRD negative CR, and the patient is either having myelosuppression, multiple infections, transfusions, or is very adamant, I want to stop. We may consider it. This may be 10, 15% of our patients. For the others, we're kind of going to 2 years. At least that's kind of what I tell the patients up front, that our goal is trying to go to 2 years. And then if you're consecutively MRD negative CR, then we may consider stopping it. But yeah, there's really no hard data that if you achieve MRD by 4 or 6 months, I would feel comfortable stopping. And all of this is flow MRD, which I completely agree with Jordi is not ideal. We don't have much data using NPM1 PCR or FLT3 sensitive PCR in HMA-Ven yet.
Yeah, exactly. And we have, as you mentioned, data now that supports the potential discontinuation based upon MRD negativity in certain subsets of patients. And we also recognize that MRD negativity is also very prognostic in the HMA venetoclax setting, as demonstrated in a recent publication by Dr. Olthus et al. A few months ago in Blood.
I think it's important to mention that all of these are follow-ups measured in months. And I think that, I'm not going to speak on behalf of ELN, but I am on the guidelines committee that is reviewing all of this, and we have new guidelines that are going to be coming out, and I can give a preview of them that basically the the statement that you made initially, Jeff, which is that biologically defined, molecularly defined subgroups with a good assay, that is the way of the future, right? So, and I think that Dr. Bergeron wrote in the chat that, you know, if you have a good assay, then you believe the assay. If you don't, you don't. We all love clonoSEQ for ALL. That's a good assay. It tells you stuff. We use it. We know what we're doing. We're happy. We want that for everything else. NPM1 PCR sort of falls into that category. We're getting happy with that. We use it, but we're still, you know, some of the patients who have other friends and family of the NPM1 mutation, we worry about them a little bit more. When the assay is good, if we have a good one for menin, if we're going to have fusion, RNA fusion panels or something that's telling us solidly, we're going to do that. And when we're in the land of flow, we aren't. So what the guidelines are going to do is they're going to be more specific on NPM1. They are going to allude to the new FLT3 data, the NGS PCR assay that is going to be emerging, as Naval just said, and that's going to be in the guidelines. And there will be acknowledgement in the guidelines of the fact that the therapy that is HMA-based is good enough that MRD negativity seems to matter. Don't forget, it wasn't that long ago that we were talking about CRs in older patients with decitabine that weren't quote unquote deep enough. So we're acknowledging that ven-based therapy for older patients giving an MRD negative CR is better than if you don't have one. But I would challenge the group that who on this call is actually taking an 82-year-old patient who is off study, doing well, and doing a bone marrow every 3 months to follow flow-based MRD. I don't think most people off study are actually doing that. If I'm wrong, jump in. But I think it becomes very challenging, and the guidelines certainly aren't going to say, don't worry about it if you have an older patient. You can use your flow MRD as a guide. It's just going to dip a toe in and say it's good if you have an MRD negative result, but it's not going to say, therefore, you're done, forget it, take the patient off therapy, they're cured.
Yeah, and I completely agree. And I think that in follow-up, we need to have, and they're being developed right now as we speak here, and I think the French group is developing a prospective study to address this very question as to how safe and efficacious is it to discontinue in the setting of MRD negativity after a certain amount of time. Let me just finish up this question. We'll send it across the pond to Dr. Platzbecker. Any thoughts on how you use MRD to guide low-intensity therapy, or is it still sort of just a general continuation approach that you've been using?
So you are questioning myself, right, Jeff?
Yeah, or as a representative of
no,
country and continent.
Yeah, thank you. Well, I think I think number one is that MRD is also prognostic, not only in intensively treated patients, but as stated by others before, it's also prognostic in HMA-ven treated patients. Also data from the VIALE-A trial were published, JCO, for instance, in 2022. I think we use it as a prognostic factor, yes, to guide also potentially de-escalation from 7 to 5 days azacitidine, because it's 4 months. So some patients, I think it's a little bit challenging, you know, the 7 days to come, especially if they are on treatment for more than a year. So I think this is a very pragmatic approach to de-escalate a little bit, 7 to 5, or maybe the venetoclax a little bit to a dose where actually neutropenia is not delaying the next cycle. So you basically adhere to a schedule every 4 weeks. So I think that's a pragmatic approach. And in some patients, when I say some, I mean NPM1 single mutated patients, maybe with another not bad risk mutation on top, who achieve very early clearance of NPM1, like during the first 4 to 6 cycles, and remain MRD negative for an additional 6 to 12 months. Again, this is not evidence-based, but rather, let's say, eminence or experience-based, and who basically have comorbidities, who decline the adherence to every 4 weeks. I think on an individual basis, so you may consider to stop therapy. I mean, there are case reports and also case series published already showing that I mean, should we talk about cure in these patients? I'm not sure, but at least we can talk about long drug holidays, sometimes 2 to 3 years, I think, have been reported. And I would not, of course, send these patients into the Black Forest and don't see them again. But again, it's like with those holidays or drug holidays in CML, where you basically stop TKIs, or you can stop it in some patients, 50% actually, at least in CML, the disease comes back. So I think you need to monitor those patients still during the first year, especially, and look whether the disease comes back. I mean, we have a patient who is off therapy now for more than 2.5 years. Others, I think, have many, many more patients, I guess. But I think that's, again, a pragmatic approach where you can, outside clinical trials and more evidence, which is needed, where you basically can treat your patient on an individual basis.
Yeah, no, thank you so much. That's I think you raised some really important points there, especially in the absence of data, the consideration of treatment modification based on MRD status that certainly takes into account the patient's individual situation and the knowledge that their prognosis is good or better, at least with an MRD negative state. So I think we've heard about the fact that MRD guidelines in low intensity therapy are still sort of in development, but that there are potential implications for MRD testing that could relate to future discontinuation or treatment modification. And as Gail mentioned, the need for more robust methods of MRD testing to really look at a full array of genetic abnormalities that could predict beyond just what we are currently using with NPM1 and perhaps flow.
Jeff, can I just make a comment? I think what Uwe said is very, very insightful. And it's also important, though, that we kind of learn from other diseases that are ahead of us, right, in MRD. And I was just at a meeting this weekend, and it's very interesting when you talk about MRD, the way CLL uses MRD is, for example, almost the opposite of how ALL uses it. So for CLL, if you become MRD negative, deep response, they look at it as intermittent breaks in therapy. So you give ibrutinib or ibrutinib-ven or whatever, obin-ven, and you're achieving good response. They say, okay, let's stop. And then it'll be 3 to 4 to 5 years before relapse. Then we'll give the person a gun therapy, and they respond. The sensitivity is high. ALL is the other way. We want to achieve MRD as a marker of completing therapy, quote unquote, potentially cure. So we pile up everything up front, with ENO or Blina or ponatinib or mini CVD, and say, can we achieve MRD negative, even CAR T? And then can we avoid transplant, reduce maintenance to 6 months or a year, and then 90% are cured? I think for us, and what Uwe is saying, maybe more of the CLL paradigm, where we probably are not going to cure tons of them, but give a break. But my concern is, unlike CLL or CML, treatment-free remission, is the disease, when it comes back, is it going to be the same disease? And I think we all know the answer to that. It's probably not. So I think the prospective study that the French and you and others may be doing with HMA-VEN is going to be critical, because if you see that 40% relapse in 3 years, that's okay, fine. But if you see that of those relapse, half of them or more have TP53, RAS, FLT3, monocytic profile, and now you cannot get majority of them back into a deep remission, well, that's the problem. So I think that is going to be the real question, I think, why we're so nervous about stopping in AML.